Across the U.S., hospital-at-home models are taking off amid the pandemic and a rapidly aging population. The hospital-at-home model provides hospital-level care in a patient's home as a full substitute for acute care. This session will discuss best practices and strategies for providing high-quality, hospital-level care to improve outcomes, reduce healthcare costs, and enhance the patient experience. Please welcome our moderator for this session, Aurora Aguilar, editor of Modern Healthcare.
Thank you, Steve. I am so pleased today to be part of this conversation on one of the most innovative and exciting segments of the care continuum that has blossomed so very quickly in the past year. The pandemic drove the world indoors and often scared patients away from the acute setting, making us all homebound. But the industry and policymakers have responded in earnest. With the goal of providing all of the benefits Steve just mentioned in his intro, the Biden administration in its infrastructure bill allocated $400 billion on home and community-based services. This is by no means the only boost given to this sector this past year. At the height of the pandemic, federal policy changes helped pay for home health services through wider use of telehealth. Some providers, like those on this panel, also invested heavily in home health care in order to expand their offerings beyond hospital walls and to ensure top quality of care. Our goal in this conversation is for you to walk away with an understanding of how this offering might fit into your organization's goals. Our guests are here to share what they've learned. Jody and Dr. Paz, I'll ask you to introduce yourselves by telling our audience how home health has aided your patients during the pandemic, and also tell us a little bit about your positions at your organizations. Thank you for joining us. Jody, let's start with you.
I'll begin. I'm Jody Lesh. It's very nice to be here. I'm the Chief Transformation Officer for Kaiser Permanente, and I oversee enterprise-wide innovation efforts for Kaiser Permanente. During the pandemic, being able to move care into the home was vital in order to continue providing services. In terms of hospital at home, it was especially important. At any point in time during the pandemic, especially during the surges, we had thousands of patients who were being managed remotely in their home using remote patient monitoring and other tools, which allowed us to keep people safe, to keep abreast of people's care, and to be able to intervene quickly, which we learned very early on in the pandemic was essential for making sure that people had good outcomes. And so we were able to do that. As a matter of fact, we even deployed staff across our organization who were not necessarily clinicians to be able to make those phone calls, stay on top of how people were doing. And we were also able to continue our traditional home health and expand some of the pilots we were doing for hospital at home in order to keep people safe and to also make sure that we had adequate hospital capacity for those who had to be in the facilities, and then be able to treat patients at home that could be treated at home. So it was essential both from a quality, from a safety, from an outcomes, and from a capacity standpoint.
Dr. Paz?
So thanks very much, Aurora. Hal Paz, and I serve as the Executive Vice President and Chancellor for Health Affairs at The Ohio State University, but also serve as the Chief Executive Officer of the Ohio State Wexner Medical Center. And a little bit about our institution. So the Ohio State Wexner Medical Center is a large health system in central Ohio, headquartered in Columbus. And I arrived here approximately 2 years ago, and we set upon a path to create a vision for the future, which was to transform the health system into a health platform. And the idea there is that we create 5 pillars, which we all have in place now, including our 7 hospitals and 16 affiliated network hospitals, as well as our ambulatory care campuses around central Ohio. And in addition to that, our clinical practice, which is about 2,500 clinicians at the medical center, a health plan. But our 5th pillar is to create a care in the home initiative that begins with identifying opportunities using analytics to create solutions beginning in the home and leveraging assets in the local community to address social, behavioral, and environmental determinants of health, in addition to traditional healthcare services. So that was the plan, that was the vision, and we had started on that, but very quickly, as a result of the pandemic, had to accelerate that transformation. And we went from doing 50 telehealth visits a month prior to the pandemic to quickly ramping up to 2,900 a day, which we're currently engaged in providing right now. In addition to that, we created a set of community health interventions, including mobile vans that went into local communities, those with the greatest need, disadvantaged communities, largely minority communities who have traditionally been underserved and were greatly impacted by social determinants of health per se. And we quickly saw that this could have a really important impact on how we could deliver care for individuals. It really validated the strategy. To date, we've done more than 370,000 telehealth visits since mid-March of last year. We've been able to improve missed appointments significantly as a result. But in addition to that, our accountable care organization, Complex Care Team, in partnership with our College of Nursing, has completed outreach calls to those at high risk for COVID-19 complications. We've used predictive analytics to identify those that were most greatly impacted by social determinants of health. We address the digital divide issues. Even though we have ubiquitous access to Wi-Fi, there are many parts of the community that have limited access, either because they can't afford a paid subscription or they lack the devices. So this team went in to assist with that. And we went into congregate living situations to help the elderly and those that needed skilled nursing care, because we recognized that they had the greatest risk for COVID-19. And finally, we distributed community care kits in local communities. Again, we viewed this as a partnership with community organizations, and we did things like distribute masks, hand sanitizers, hand hygiene items, and then set up testing and now more recently vaccination centers in those locations, because we viewed that as the opportunity really to reach into the home, into the local community, but most importantly, use predictive analytics to allow us to create these partnerships, these interoperable partnerships with the local community.
That digital divide question is going to be something that I'm going to ask you too in just a second about, but you talked about these networks and having sort of tethers to the community that are so helpful and necessary in being able to reach out to people in their homes. So Jody, can you talk about the work that Kaiser's done with Medically Home?
Yeah, I mean, we as we were building we've had a very, first of all, extensive home health part of our business for a long time. So we insure just about 12.5 million members. So the question is, could we do things like hospital at home at scale during the pandemic? So we entered into a partnership with an organization out of Boston, Medically Home. They're a startup organization that we've made some investments in to stand up hospital at home pilots in 2 of our regions, in addition to all of the remote patient monitoring that was a part of our extensive home care platform as well. So we have kind of a number of stakes in the ground. One of the things that we've learned a lot from Medically Home is really the unique supply chain challenges of being able to do hospital at home, by being able to get things to people very quickly and to be able to create this sort of rapid response, as well as this 2-way or 3-way, in case the patient, the provider, and the command center communication, which is so critical. And then working with paramedicine to be able to bring people and leverage the resources in the community to bring people into the home who can, do the infusions and wound care and all the things that need to be done. So, and I do want to mention, I do think it's really interesting about the community connections. I want to say that because like Dr. Paz, we've realized, we knew before, but certainly COVID-19 accelerated our understanding of the divide that we have, the health disparities that we have in the particular communities that were hard hit. So one of the things that we actually launched in, about 2 years ago with a company called Unite Us, which is a platform that helps people, our providers and eventually members, connect to community resources. So our branded version of it is called Thrive Local, which is to help create those connections and referrals and to have a closed loop system. So we not only make the referrals, but we understand who's responded to those referrals and what the impact, and over time being able to understand the impact that it has, meeting things like food insecurity, transportation issues, home care, caregiving challenges, financial strain, all that. So we completely are on the same wavelength, really understanding that much more deeply than we did prior to the pandemic, and really building the solutions to build out and reinforce the community the community organization network, and then to really build that into our medical record, which we've been working on with our EMR to not only be able to do screening, but to be able to do the referrals to these and understand that closed loop, and eventually understand and be able to study and do research on the impacts of being able to meet those needs. So it's just kind of a very multi-layered strategy. And I agree with Dr. Paz. We had the strategies in place, but they were really put to the test and kind of put on steroids during the pandemic, because the needs were so great. We can ask us some questions about the digital divide, because I do think that's continues to be a pressing issue, even though we've made some strides in trying to address it.
Well, the records too, which I understand has been a significant issue for making sure that the information is sort of being shared amongst all the people that are caring for people that are outside of one facility. So I'll ask you about that too. One of the things that I saw in surveys of patients that were being cared in the home is that the lag time in that supply was often an issue. And so perhaps not being able to have all of the things that they might need at their disposal in order to have the clinicians and everyone that was going to be coming in to support the patient readily available when they were transitioning to the hospital. Dr. Paz, Wexner, Ohio State made an investment into a joint venture into Ohio State Home Medical Equipment.
Yes.
Is that the reason why? Was that what you were trying to address? And why was this the right move for your organization?
Yeah, so that's a great question. And, our philosophy is we don't have to build everything ourselves organically. And I think that often becomes a rate limiting factor. And quite frankly, it allows us to focus on our core sets of skills and then find the right partner to build out businesses that create opportunities for us to engage in the community in a number of different ways. So this is one example of that. Through a joint venture, we created Ohio State Home Medical Equipment. And as a result of that, we had the opportunity to leverage that knowledge base to move medical supplies into the home. We have the ability through this arrangement to have accountability for mutually agreed upon performance and quality metrics. It allows us to reduce our hospital expenses through better HME inventory management. So that's an opportunity. And as we learned during the pandemic, it gave us a chance to really provide the supplies that were necessary. We've used that same view now to we're in the process of creating a host of other partnerships in a similar way. One is home health care. Another is in our looking at opportunities to create more mobile vans, which we already have undertaken. But we're trying to do more and more of these things on scale. And we think using partnerships is one excellent way to move this forward as quickly as possible, because the field is so dynamic and the changes are happening so quickly that this gives us the best chance of really responding in ways that can be innovative on one hand, but responsive on another. And I would add that, we have a very special responsibility at the Ohio State Wexner Medical Center, which is Ohio State has probably the largest health science campus in the nation in terms of having 7 colleges of the health sciences, 10,000 students who are getting educated in medicine, nursing, dentistry, pharmacy, optometry, public health, even veterinary medicine. And the focus is to educate these students in interprofessional teams while they're still in school, not educate them in silos and then wait till they graduate and hope that they can become better educated and working effectively a team. So teaching them a common language, teaching them similar care paths, so when they're deployed, they can do this effectively. So these types of approaches become models for that educational process. And our hope is to focus on educating them for what health systems look like in the future, as opposed to the way that care has been delivered in the past. These are opportunities for us to then do more research as well and understand what does work and what doesn't work, so that we can continue to not only refine the educational programs, but also make sure our investments in the clinical platform is effective to meet the needs of the communities that we serve.
So a major partner that sometimes is often difficult to wrangle is the payer. And in this case, Medicare is the single largest payer of home health services. And last year, MedPAC recommended a 7% cut in payments for this upcoming year. The reason being that Medicare margins were considerably high. In 2018, 3.4 million Medicare beneficiaries were provided fee-for-service home health care at the cost of more than $17 billion. In fact, this portion of spending is one of the largest in the Medicare budget. In your opinions, what are the biggest payment and regulatory challenges to home health care? Jody.
Yeah, this is I think, a very, very significant issue. We saw some nice movement during the pandemic, but, these were more on an emergency use basis to be able to do hospital at home. And one of the things that we're doing right now at Kaiser Permanente is a deep analysis of what we believe the whole continuum of services in the home is likely to be in the future, and really look at the size of those populations. So anything from, hospital at home, SNF at home, palliative, primary care, complex care management, and really understand what those populations, the size of them, what they need, and what we believe the expected benefits could be. And then use that information to not only build our capabilities, but also determine where we should be influencing the regulatory environment. And I think we've all seen this consortium that was put together as Moving Health Home that was really focused on influencing policy. And I think that's critically important, because right now, we even fought early on, right, for reimbursement for telehealth, and we continued issues with reimbursement for care in the home. Right now under Medicare, it's quite narrow. The length of time it takes to be able to apply for expanded Medicare benefits is lengthy. It's a very arduous process, and we think the market's moving faster, than the regulators in this way. And so, I do think that expanding what is covered in the home is going to be a continued area of policy discussion and influence from not just the payer or provider community, but all this really big startup community, Dispatch Health, Medically Home, and others who really see the potential, but also see their business models potentially at risk if we can't get reimbursement for the types of services that we know are needed in the home. So I think the regulatory, the policy environment is a barrier. It also could be a great enabler, and I hope that we can move in the way of it being an enabler, but there is still work to be done in that front.
Dr. Paz, what are some of the opportunities you're seeing?
Well, I should mention that before I joined Ohio State, I was Executive Vice President and Chief Medical Officer at Aetna. And one of my responsibilities there was to launch Aetna Care, which was about how we used analytics to identify patients with the greatest needs. So those were patients with chronic illness. We hired nurses who literally went into the home, and then using telehealth, and this was 5-6 years ago, used telehealth, worked with physicians and ACOs, and then an array of solutions to keep those patients out of the hospital, to keep them out of the emergency room. And without a doubt, that approach worked best in a value-based reimbursement setting. So the physicians were rewarded for success. We even brought in pharmaceutical companies, like we announced, for example, Merck was a partner, because we knew that medical adherence, 3 months after a diabetic patient gets a prescription, only 50% of those patients are adherent to their meds. If you can get patients to be adherent, you're going to increase the likelihood of them being kept out of the hospital, and keeping them healthy is the most important thing. We partnered with supermarket chains like ShopRite, and we used nutritionists to educate those diabetic patients about healthy diet and nutrition. So I think that even going back 5-6 years ago, there was a really good understanding of why care in the home was so important. At the same time, this works best in a value-based setting. And my hope is that more and more health systems like ours will get rewarded through those type of reimbursement mechanisms for doing these things. And until then, we're really left with a fee-for-service model to address this. And I recognize that. I think there are things that have to happen. We have to, over the short term, expand the number of services that are covered in terms of home-based settings, such as higher acuity services. We have to retain flexibilities created in the acute hospital care at home program, AKA the hospital without walls. That's going to be very important. We have to maintain a comparable payment rate for telehealth. with in-person visits. And we also should find ways for pharmacists to be billable providers. Our College of Pharmacy here and our pharmacists are actively engaged in making sure that we're addressing these issues around appropriate medication therapy, as well as issues like adherence. It's an important part of keeping patients out of the hospital setting, which arguably saves cost. The other point is, we're seeing at our institution, our inpatient facilities on any typical day are 95% full. And we want to make sure those beds are being used for the right patient at the right time, for the critically ill. We saw this during the pandemic. Many hospitals saw this during the pandemic. I think communities and payers, arguably, are all well served by us figuring out how we get rewarded for providing the right care at the right time and the right place, if the reimbursement models support that.
And then,
I can just add one thing. It's interesting because one of the things that I've been very pleased to see is in the Medicaid program, this in lieu of services. So looking at things like, transportation and food. But it was interesting because we actually implemented prior to the pandemic and then tried to expand the program during the pandemic to address food insecurity and get, medically tailored meals home and other types of like coupon programs that would help increase people's purchasing power. And in some cases, we did hit some roadblocks in Medicare that this was treated as an inducement. And I think those are just kind of the roads that you go down, and then you hit some roadblocks. And I do think that the policy landscape is influenced by us going in there and, to Dr. Paz's point, articulating what care is really needed. And sometimes it's in lieu of, traditional care. It's things like food. And I think we just need to continue to push that. And I think we're making progress because as I see like in the Medicaid program in lieu of services and you see that we were actually eventually able to get through some of the Medicare roadblocks with providing food. But it's a tough environment to navigate. The regulatory environment is not always friendly to innovation. But I think it's important that we push because I agree that there are many services that we can provide that will reduce utilization, reduce costs, increase quality, and improve outcomes and satisfaction. And they're not necessarily the typical benefits that are covered under the typical payment system. So we just need to continue, I think, as an industry to push on that and shed light on the importance of those types of programs.
So we actually only have 15 minutes left, and I've got about 17 other questions to ask you. So I'm going to try and hit just the most important ones. There have been innovations recently, and you both talked about some of them in addressing all kinds of ailments at home, even dialysis. So what kind of patients are you finding the most success in transitioning to home health care? And what's the best way to ensure that the digital health support is there to ensure that success? Let's start with Dr. Paz.
I think in terms of patients with chronic illness, the diabetic population is, for the reasons I mentioned earlier, I think a great opportunity to look at care in the home. And there have been a number of efforts already underway, both through traditional providers of care as well as the so-called disruptors who are using digital and telehealth solutions to do this. Many of the things that need to be focused on is making sure that there's medication adherence, making sure there's appropriate monitoring, and a lot of that data now can be sent back to the provider in real time so that that information is available. And the use of analytics obviously is another way to do that. The other population where I think there's enormous opportunity, again, we've looked at this as patients that have cardiovascular disease, particularly congestive heart failure, for example. Again, it's another opportunity for us to see how we can transition some of that care into a home setting. A lot of it will depend on the devices that are available, but also access to the web so that the information can be exchanged in real time. And again, that's why the digital divide becomes so important, particularly for at-need communities and patients at need who don't have access to those basic resources that many others do.
Mhm. I was reading that not just the digital divide sometimes creates that gap between urban and rural areas, but also just the services that might be available for home health care seem to be more skewed towards urban areas than rural. So what are you sort of seeing as far as challenges in regards to the digital divide, and then also to the support that you might have in one area versus another? Jody?
Yeah, we've been really delving deep into the digital divide and really kind of reframing it as a digital equity issue. There are certainly issues with broadband availability, and there's lots of different sort of estimates of how significant that gap is. Probably a lot larger than the FCC has given credit to. But there's also there's access to devices, and there's also issues with digital literacy. And I was sharing, Aurora, when you and I were talking offline the other day, that we are implementing a program to support care in the home kind of on a number of fronts. One is to put more tools in the hands of patients and their caregivers, kind of a purpose-built application, things like they can manage their schedules, they can manage tasks that are given for their care, they can have seamless communication, they can connect to remote monitoring more easily, kind of one touch. And it's interesting because most of the patients enrolled in this pilot are older. I mean, I would say somewhere between 70 and older, and you would think that the older people get, the more challenging it would be. And we actually have a patient who's our super user, we call her. She's 101 years old. She's never enrolled in any of our flagship app or our website, and it's interesting. So, and yet we have others who are really struggling. So the issue of digital literacy is not just about income, and it's not even just about age. And also one of the things that we've learned about is that, we, in this particular program, we're actually not relying on broadband. We're using cell coverage, which also can be a challenge. But how we build these devices can also increase access, because access to phones in some cases is much better than access to computers in some areas. So we really need to look at the digital divide, I think, more broadly than just the broadband access, which is a very significant issue. And I'm happy also to see investment in the infrastructure bill to really build that, both in terms of availability and speed. Because, if you could do a phone, but you can't do a video, then you can't look at a wound. I mean, there's many things that you can't do. But also really look at that literacy, look at access to devices. And also the one thing that we've been pressing is adequate technical assistance. So if anybody has an elderly mother or father or relative, I'm sure you get phone calls about technical assistance. People are having trouble in real time and need answers in real time. So we've been really exploring this area and trying to think about it very broadly. And I'm excited to see what we continue to work on, in addition to influencing policy around broadband access, which is critical.
I would agree with Jody. I do get those phone calls, and I couldn't agree more. But that being said, I think that the issue of digital literacy is really important. But fundamentally, when I think about access to care and I think about social determinants of health in the underserved, we looked at some data here in central Ohio in our own Franklin County, which is where we're headquartered. And this is from the American Community Survey from the census in 2019. We found that 1 out of 5 Franklin County households don't have a cable modem, digital subscription, or fiber internet accounts. And 10% of the households had internet access only through a cellular data plan. There were almost 50,000 households in the county that had no home broadband subscriptions of any kind. And this disproportionately affects the poor. Household incomes below $35,000 were made up a quarter of the households, but they made up 70% of the homes that didn't have any internet access. I mean, that's incredible data.
Yeah.
And I think that it's really going to be important if these approaches, these in-care home approaches, which do depend so much on telehealth and do depend on digital data being acquired through, let's not even worry about wearables right now. Let's just figure out how we get a device into someone's bedroom to measure things. But if we can't connect that to the internet, and then we can't bring it back to our medical center to then track, it becomes very difficult to execute on these programs with the degree of confidence that we need to have to be able to move someone out of the emergency room and send them back to their home instead of admitting them to the hospital, which is the last place they want to be, and it's really the last place we want to put them, but we can't do anything different if we don't have the resources embedded in the community and the affordability to address that.
So given that there are huge challenges like that that might be difficult for you to be able to influence immediately, what do you both see as the future of home health care in being able to really help advance some of these goals that you've got for each of your organizations? Jody?
Yeah, I mean, I still think, even with all the digital access, I do think there's a significant role for sort of in-home care for patients, and not necessarily lose that touch. It's interesting when you talked earlier about the types of populations that would do well and we're looking at for care at home. It makes me think of people who have very complex needs, and that's both from a medical perspective and also kind of a psychosocial perspective. And I don't think there's a substitute sometimes for going in the home. And then the question is, how do you make that efficient as possible? We're working on things around, even things like scheduling. How can we make scheduling more, more efficient, automated, optimize routes? Look at some of the learnings from, the UPSs of the world and Amazons of the world, and looking at things like supply chain and how can we do better at getting things more timely into the home. So I think there's, even though it will be, difficult to move the issue on broadband access, I do think, first of all, as an industry, we can come together and put pressure and explain. And I think we're already starting to see great movement in that. But there's also a lot we can do, even with simple technology, even with, with phones and getting people into the homes in ways that are more efficient, and we can sort of build models that, some of the things we're working on is sort of purpose-built technology for mobile documentation in the home, which is very slow today and kind of cumbersome. How do we make that easier so that our nurses and other care providers in the field can, see more patients in a day and spend more time with patients and less on, going to a Starbucks and trying to download and document and things like that. So there's many parts of this solution. They're all necessary. Unfortunately, one isn't more important than the other, and we're going to have to work on all aspects of it. And I agree with Dr. Paz. I've heard the digital divide referred to as the super determinant of health, and it really has the potential to improve access and reduce disparities, but it also has the ability to exacerbate disparities if we don't do it well. And it's just imperative that we don't allow that to happen.
Dr. Paz?
I would say I'm fully confident that we're heading in this direction as an industry. There's no doubt about it. We're the last industry in the U.S. economy to go through this transformation. We've already seen it occur in banking and retail and transportation. And the way that it rolled out in all those segments has been uneven, to say the least. And in some cases, it was driven by large organizations, but in many cases, it was driven by startups and so-called disruptors. And some segments of the population took it up much sooner than others, but eventually it had this impact across the entire U.S. population. Look, healthcare is the largest percent of the GDP. It may be the last part of the U.S. economy to go through this transformation, but we all know that embedded in that over $3 trillion of spend, by most estimates, is about 25% of it, or about $1 trillion that is wasted. And any type of solution that arises that can address that waste, repurpose it, and find ways to put that back into local communities will be definitely a winner. And I think that's the greatest opportunity we have. How do we use this technology, rather than just admire the technology, how do we use the technology in innovative ways to address waste and inefficiency? How do we better organize care? How do we make it more and more interoperable? So at the end of the day, we're addressing the things that have the most to do with health and well-being and not dying a premature death. And I think that's the greatest promise that we have for these technologies as they evolve over time and as they impact more and more individuals, beginning in the home, creating personalized health experiences.
Especially because one of those stats that I was not able to reference was that by the end of this decade, it is estimated that an additional 1 million workers will be needed for home-based care, because 70% of older Americans will need various aspects of home health care for usually a span of 2 to 4 years. So this will be incredibly important. Thank you both for joining us today. I think we're going to be
Thank
moving
you.
on to questions from the audience now.
Thank you.
Thank you very much.
And we are back. So as I think you might have noticed, we did tape that earlier segment. So there is a question that I really wanted to pose to Jody back when we taped that I didn't get a chance to. That Scott Jocelyn, the CIO at UCI Health, is also interested in hearing about. So what drove the decision to have Kaiser partner with Medically Home and Mayo and invest $100 million into that platform? If you can tell us, Jody.
Yeah, no, I think Dr. Paz really actually hit the nail on the head, which is if we want to make quick progress on innovation, sometimes we need to accept the fact that that innovation doesn't come from us, and we need to figure out how to integrate it into our business. We had actually been partnering with Medically Home. We had a couple of pilots with them pre-pandemic in a couple of our regions to understand the hospital at home model. And one of the things that we really learned from them was they had great expertise. They had a purpose-built technology for this. They had worked on the supply chain issues. They had worked on the protocols for care in the home, for hospital care in the home. So they were a number of years ahead of us. So it made good sense that we partner with them. As we started partnering with them, we also understood that Mayo was partnering with them as well and learning about the model. And so the two organizations came together, and in order to really help that business go forward with a sizable investment and to promote this model of care that we think has so much potential, we decided, Mayo and Kaiser Permanente, to come in together in this $100 million investment, along with a few other investors that were already existing. So we're very excited to grow that business. We're very optimistic. Medically Home, also, their leadership had been very engaged on the policy front. And had a head start, and we're really seen as experts and really seen by policy people in the policy arena as really understanding this model and could explain the benefits. So this was a way for us to accelerate this innovation. We're very, very excited about it. I think it's going to advance. And we also think that the two organizations, both Mayo and Kaiser Permanente, bring tremendous clinical expertise to this space, obviously in caring for large populations in the hospital. So we think it's a really good marriage of experience and expertise that we both bring that's different and complementary.
Dr. Paz, not to be left behind, I'm not going to put you on the spot, but we will be breaking news, I expect, later this week for your system as well.
We have several announcements that we plan to have come out in the next few weeks. We're actually going through our board meetings this week, so look forward to that. But we've had a few up until now, but this is a path we continue to take. And I view it as putting together an array of different solutions that we make interoperable for us and for the communities we serve. And in many ways, we take advantage of the private equity, the venture capital dollars that go into these startups, again, these so-called disruptors, and then find ways to partner with them. And they seem to go through their own natural evolution. They may start out as direct to consumer. They may then go direct to payer. But ultimately, as we're learning, if you find the right partner working between one of these companies and then a system like ours, really creates long-lasting opportunities to make significant change. And I think it really creates a mutual win-win, because it allows us to, as Jody said, bring our knowledge-based expertise to the table, our reputation and patient population that we've garnered over decades, literally, and then match it up with some of these really great new exciting ideas that the private world has funded and wants to see be successful. And I think that's a great thing for the economy, but most importantly, I think it's a great thing for those that we serve.
So I'm going to combine the last two questions because they're both kind of related. So Scott Jocelyn again and Atul Chabra, the director of Alto Strategies, asked together they're kind of wondering what the role of EHR is in capturing and being able to help with devices and at-home monitoring. So Dr. Paz, if we can start with you. I think are you both on Epic? Is that correct?
We are.
Okay. Okay.
Yeah, let me say that, we're very fortunate here. Disclaimer, the Wexner Medical Center has been an early adopter of Epic and, Beta for a lot of the innovation. And I have to say that we were very fortunate, during the pandemic, for example, to have that kind of a platform and then to integrate telehealth into it. It really simplified our ability to use the technology in ways to create the integration. And I think, it's an important point that the kind of technology that we use has to be scalable. It has to create some kind of a value proposition, either improved outcomes or lower cost, but ultimately it has to be interoperable. And if it's not interoperable, it creates huge challenges for adoption. And I think for anyone that is starting a company, developing new technologies, that has to be front of mind. So having a platform to integrate these things into, and that's why I talk a lot about the need for more and more interoperability. That's where it becomes essential and really, really important.
Jody?
Yeah, I just couldn't agree more about the comment about interoperability. If we can't collect this type of information in the EHR, then we lose, this sort of longitudinal view of our patients, which was really the impetus behind electronic medical records to begin with. And so as we're looking at some of these startups or other partners, they really, these organizations really do need to look at how to do that integration, which is possible and sometimes challenging as well. It's interesting. So, we've certainly been doing that with our remote monitoring, but even with Medically Home, we're still working on that integration with them. So the integration can be quite challenging. Supply chain, another good example of really having to be the integrated, because at the end of the day, Dr. Paz, you mentioned also the importance of predictive analytics. If you don't have the information, then you're going to be, you're going to be stymied in your efforts to do predictive analytics. I do think, it's funny, we sort of passed over wearables and things like that. Those are obviously some of the next frontiers, as well as sort of ambient monitoring in the home, which we're seeing more of as well. And we're just gonna, we're gonna have to get into the interoperability of those, because I think they're a long way off, especially the ambient monitoring. But it's essential. If we can't see the whole view of the patient, then we will lose a lot in the value of doing some of this monitoring. But it's possible.
Jody's absolutely right. So much of the technology now depends on the patient or the individual taking an action. And when we get really good at this, it shouldn't need to. It should be ambient. It should be a wearable. One example is Alzheimer's disease. So this is a huge issue. Talk about chronic disease in the home. 6 million Americans currently have, or 5.5 million, have a diagnosis of Alzheimer's disease. It's estimated to triple to 14 million by the year 2060. The opportunities there are enormous. So this aging elderly population, the need for more home health care workers, the shortages that exist right now. I think the better we get at this and the more ambient the technology can be in the home, I think the solutions will become much, much more elegant, without a doubt.
Well, thank you so much to you both. This was a wonderful conversation and tons still to be able to talk about, which we will have our reporters diligently call you about as the sort of the results of all of your partnerships come to fruition. So thank you both so much.